for simple cases to be explained to them, especially in the bifurcation. And as we all know, we have as an interventional cardiologist to master the bifurcation, 1 or 2 bifurcation techniques. To be an expert in interventional cardiology, you have to at least to master 2 bifurcation techniques. My case today is the male, 72 years, hypertensive, current heavy smoker, presented to me with severe chest pain 6 hours prior to admission. 150/90 blood pressure, heart rate of 90 beats per minute. The ECG showed at that time ST segment depression from V1 to V6. And here also we have electrical instability, which should be considered in our decision and our strategy of management, that this patient is electrically unstable with non-sustained VTAC runs. His echocardiography also, which is done immediately bedside, hypokinesia of anteroceptal wall segment with ejection fraction actually preserved, 55%, and mild mitral regurgitation. Troponin withdrawn with highly positive result, serum creatinine 1.2. The patient was loaded immediately with 180 milligram ticagrelor, 300 milligram aspirin, 80 milligram atorva, and the Clexane shot was given to him. And the patient actually pushed to the cath lab because he is electrically unstable with nestomy presentation. Let us dive in his coronary angio first. As you see here, an ostial circumflex of about 90%, 95%. Also, there is a mid LED. And by looking here, we have a bifurcation in the distal left main. We have paraostial or ostial left circumflex of 95% lesion. We have a proximal to mid LED atheroma with maximum significance, maybe at the proximal segment with about, as you see here, of 90 or 95% lesion. So now we have an extensive LED and LCX lesions. The left main, it seems to be normal, but we have ostial and proximal LED and ostial LCX. The RCA, I think, is small, the vessel. The decision here is because of the patient is electrically unstable and he is nestomy, and we have to do something for him immediately, is to proceed with intervention. And of course, we will proceed by a bifurcation technique because here we have involvement of the ostial circ and the proximal segment to mid segment of the LED. Of course, 2 wires are pushed in the LED and the LCX. And then we started by stenting the med segment of the LED, as you see. And this is the first step, of course, is to stent the med segment of the LED. This is to facilitate the further steps of the procedures. And here, thereafter, we started to intervene with the circ. So first step here, that we did the med segment of the LED. Then the second step is we started to intervene in the LCX by doing a DK crush. With the first step in the DK crush, that we stented the ostium to the proximal segment of the LCX, as you see here. This is the stenting of the LCX. And we have, as you see here, a balloon parking in the LED to do the first case, as you know. This is here is the second step in the DK crush, is to do the first case after the deployment of the first stent in the LCX. Now we will see here is the first case, as you see. This is the first case. Then we started the third step. The third step here, I'd like to go a little bit backwards. is the stenting of the LAD. As you see here, there is an important step that we remove the wire from the LCX. The wire is already removed. Why? Not to be jailed between the two struts metal. So, and now we see the deployment of the stent in the left main LAD. And then we do optimization of the stent in the LAD by doing balloon dilatation from distal to the proximal segment of the stents, as you see. And then we do the first bot. Here is the first bot. And as Professor Ammar mentioned in his case, we have to be careful that the first bot should be above the carina of the bifurcation. So now in the step of the first bot, and this is the result after the first bot. The coming step is the recrossing and then doing the second step. So now we recrossed, opening the struts, then we do the second kiss. So now we are in the step of the second kiss. And as you see here, the two balloon inflated for the second kiss. And then the final step, which is the second bot. So the DK crush is one of the best techniques in doing the bifurcation, especially in the distal left main, but it must be done step by step. This is here, as you see, the final or the second bot above the carina, and this here, the final results after doing the distal left main, ostial LCX, osteoproximal LAD to mid LAD with, I think, satisfactory results step by step DK crush. I know it is a simple case, not heavy complex, but here is the message, is the step by step. And also my take-home message here is very important. It is not the matter of the technique. It is to do, it is step by step to optimize your results and to improve the long-term outcome, because not we are looking for the angiographic short-term results, but also we have to look very carefully to the long-term outcome, and this should be fulfilled by step-to-step approach when we are managing the bifurcation. And thank you for your attention.
Excellent case, Professor Syed. As usual, طبعا in this case the angle was wide, and so you had also other options. Even you can even use the T technique because it's almost 90 degrees. But you want to have complete coverage of the carina of the distal left main. Maybe that is the reason, but it was outstanding results.
Another reason, Professor Magdy, actually for this case, at that time, there is a strong evidence, which may be not the case now, that the DK crush is one of the best techniques to be used in the distal left main as regard the long-term outcome. And I'd like to hear also from the experts, I'd like to hear from Professor Amin Fouad. What is your preferred technique in the distal left main bifurcation as regard the long-term outcome?
Actually, this will depend on the angle, as Dr. Ahmed Magdy is saying. When we have an acute angle, DK crush will definitely be the best option as a short term and a long term. But when we have an angle such as this is more than 90, this is around 130 angle, I can live with a tap here. But for the long term, DK crush is definitely the better on the long term on any angle. It will be the best. And I think this case is very nice and it is well done. And I have to recall what Antonio Colombo has said, that if you don't have an ostial left main and the long left main, it is not mandatory to go to the ostium because it will make your life maybe more hazardous while rewiring. So sometimes you rewire from the cell that is outside the ostium of the left main. So this case is very nicely done. And if I were in your shoes, I will do the same exactly. So this is very nice.
Dr. Yasser, I feel I see you that you feel comfort on the beach over there behind you.
لحظه بس يا دكتور سيد، ايمن خيري كان ريدي يقول كومنت بتاعه.
ايمن خيري اوكي، بس عشان انا شايف ياسر ممكن يكون زعلان مني في الحلقه.
لا I have a comment بس بعد دكتور ايمن يعني.
اوكي.
A very nice teaching case as usual.
ربنا يخليك.
And Assistant Halik, I would like to ask about why did you cover the whole left main?
Not the whole.
I believe the ostium of the ElNady was not very diseased. Do you have ideas that you just
okay,
put?
it's a very great question. It's a very important question, and it's always asked when we are doing a bifurcation in the left main, especially if we have a healthy left main. If you have a healthy left main, here is the question: do you will cover it all, or do you leave the a part of the left main? Actually, in all the intervention procedures, especially the bifurcation, there is no guidelines. Why there is no guidelines? Because there is from case to case variability. If you have such a left main, it is not so long left main. It is, I can see it is intermediate length left main. I think after we put the stent, which should be part of it in the left main, we will leave about 2.5 millimeter length uncovered in the left main. And from my experience, and I don't know the experience of others, if the distance you will leave it is 2.5 or less, it is better to cover, because the incidence of restenosis is much more higher if you have an occult, even not apparent atherosclerosis. If you have an occult atherosclerosis which are not seeing by an imaging like IVUS, you will have a high incidence of stenosis at the proximal segment of the stent.
يلا quick answer, a quick comment from Yasser. Yasser, عاوز quick.
Dr. Said, excellent presentation as usual. I like your step-by-step manner. It's educational. But let me ask you about the long-term prognosis about two-stent technique. Actually, I know from literature and the publications that DK crush is the best way to treat distal left main. But actually, when we follow the patient for long term, I think the rate of restenosis is still high. And I saw patient after 6 months, and he did left main stenting in France, and now he complaining of non-STEMI. And when I did for him coronary angiography, I found that he had restenosis in the ostial circumflex. So I would prefer to go back to one stent technique after I faced a lot of stent restenosis. I know that there is an obligation in some cases, and you have to do two stent technique. But I think we have reconsidered that DK crush is not the golden rule for stenting. And when I asked Diaz, he preferred to do T-stenting in each T-stenting. Why not to touch the metal to metal in angle like this? Why for the long-term prognosis? So what do you think about this?
I'd like to thank you very much, Professor Yasser, for this elegant question. Actually, to make the short answer, we have 3 arms. First, the patient arm, the patient profile, the patient risk factor control we have to consider. This is number 1. Number 2, we have to consider the procedural aspect. The procedural aspect, I know that every distal left main should be optimized by imaging. So this is the second arm. So we have the procedural arm. So we have the also the angiographic arm and the lesion arm. If the lesion is long lesion in both vessels, the main artery and the parent artery, you should go for 2 stents optimized by imaging and optimized by the risk factor control of the patient. If you have both, I think the outcome will be great.
Okay, I think we need to move. Thank you, Syed, very much for the excellent case. And now it's my pleasure to introduce Professor Basra Abdelhamid.